Good morning, everybody. I hope you had a good coffee break. And now it's time to start the first live case in this year BEC meeting. Everybody is expecting a case of deep loop carotid case, yes. We're expecting live from City Clinic.
Okay, do you
Professor Petrov and Professor Zoran Stankov, I think.
Hello, guys. Do you hear me? No.
Yes, perfect.
Excellent. In fact, it's our pleasure. I would like to introduce you to Professor Stankov, Professor Stoikova, our nurse, one of the most experienced nurse, Nadia, Lydia, our X-ray, Iskra. You probably saw and heard in fact part of the history. In fact, it was a quite the symptomatic patient with critical stenosis of the left carotid. That was treated in the previous session. Did you see it?
No, you are just at the moment live.
Okay,
with a picture.
With a picture. So this is the result after the previous session. It was about 20 days ago. The patient was symptomatic, young patient, very motivated, and during that hospitalization, the previous hospitalization, it was evaluated for 70 to 80% stenosis of the right carotid artery. And you probably observed that, in fact, the catheter is coming across from the arm. Our experience is 60% arm approach and 40% femoral. And you can see the right carotid artery that was the possible target. Of course, I will ask for your opinion. And I'm particularly curious about the duplex investigation, what they have found, what are the speed of this stenosis. It looks not significant for me, but you know that as a cardiologist, we like very much functional investigation and also intravascular investigation. And I would like to be confident that we have reason to treat or we have reason not to treat. Professor Stoikova will show you tomorrow the very interesting results of our STRING trial. This is the trial for subtotal carotid stenosis. And in STRING trial, we saw how important it is to have the evaluation of the flow and the velocity. So we are performing the DPR routinely. And what do you think? What do you think, the panel?
Hi, Ibo. It's Rebecca.
Yes.
And
yes, Rebecca.
Could you tell me the ultrasound findings before you decide to do this arteriography?
In fact, what we are planning to do now to make a live investigation, both IVUS and also FFR, DPR. In fact, it's like the more modern pressure gradient.
Okay, thank you. And besides that, I want to ask you the symptoms of the patient. How severe are they?
Speaking about the contralateral symptoms, he's asymptomatic. In fact, the reason to plan him for a second intervention was the finding by the duplex of 70% stenosis. And we have usual practice above 70% to make also intervention. And but in this situation, I am a skeptic.
Okay, thank you. I don't know if there is.
I will ask. Yes.
Let me ask if you have any questions, comments, nothing. Okay, just tell me.
In fact, we are proceeding with the IVUS, and you are going to observe the results of the IVUS measurements.
Ivo, can I ask you, this is
Of course.
invasive procedure, so will you use some kind of protection for passing of the IVUS catheter? We
Yes.
Yeah, in fact, we put already now, Professor Stankov will show the marker of the filter.
We can see.
You see the point
it's
over
visible.
there? Yeah, this is the point of the basket. We are using routinely so this is quite distal.
Yeah.
Quite even surface without any problem, and we are going to perform a pullback. I can guess you can observe the IVUS picture.
Yeah.
Can you see? Yeah. Okay. Excellent.
No.
So we are going to proceed.
We cannot see the IVUS picture.
Now we show you.
Да случи камерата към IVUS. Now we are going to do our best. Now we are going to do.
Okay, stop.
Мите, към коя камера? А дали не можеш? Мите, дали не можеш с горната камера да я насочиш към екрана е тук?
Ще се опитам.
Виж. We are do our best to show you the here. The IVUS.
FR катетър пригответе.
Ма прекрасно. Вълшебници. Okay, excellent. I checked what we are seeing, and I'm now sure that you are going to see what we are investigating. In fact, this is the pullback that we have just performed. Now, in a moment, you are going to see the bifurcation. We are still distally, nothing special. Now the plaque is. Oh, yeah.
Return.
Okay. Okay. Now I will ask Lydia to go back above the bifurcation and to measure. More. So you see the plaque is not neglectable. The plaque is not neglectable. It's okay. Давай надолу пак. Okay. We are going to measure the minimal lumen area and minimal lumen diameter. Go down. Up. Back. Okay, not bad. Go ahead by dots. We are going to measure now the diameter and area stenosis. And we'll decide together with you to do or not to do. To be or not to be. Я май пак да го мръднем малко нагоре-надолу. Да, окей. Delete. Махай го. Искам да хвана. Чакай. Okay.
Ivo,
Чакай. Yes, Rebecca.
which are your parameters to do it or not to do it?
In fact, on this level, this is very good question. You know how important is echolucency, stability of the plaque, not only the percentage of the stenosis. And because of that, the question that we are in fact raising is very important. It's in fact a mixed plaque with mainly fibrotic tissue, practically, and some calcium. You see half of the circumference with calcium.
We cannot see it right now.
Yeah, between 12 and 6 p.m. You see the calcium burden. And okay, no thrombus.
Още надясно можеш ли или наляво да се тръпнеш хубаво? Супер си.
So you see the calcium here?
Yes. Yes.
Yeah, this is the calcium, and we are going to, and this is close to bifurcation. Again, quite a abundant plaque, but the lumen is very good. And now we are going to find the minimal lumen in order to measure and to have notion about the stenosis. Okay.
Ivo, I have a
Yes.
question. How is the patient? The patient is awake?
Oh, yeah, definitely.
Okay.
This is absolutely, for such a procedure, it's very important, especially for the intervention, the patient to be awake in order to control his neurological status.
Yes.
And yes, he's awake. We can discuss with him, and I will explain him what is our decision after making. Okay, probably this is the smallest. Zoran, ти какво мислиш?
Малко надолу.
Още малко.
Да, върнете. Тук. Да.
Okay.
Yeah.
This one. So we are going to measure here.
Наляво може да отиде тама.
Литка. Чакай още малко. Това е.
Ето това е.
Окей, давай това не го мърдай. Стоп. Дот, давай. Значи първо по вътрешния диаметър и после по това големия. Айде. Yes.
Да.
We are going to put Dot's measurement. We can vote. I'm telling 50%. Yeah.
How much?
Да.
What is your opinion? How much will be the stenosis? Okay. Давай.
Да, така.
На ръба.
И премести ги и горните ли да? Че така ще изкараш 30.
Тук. Айде, давай. Done. We are going to measure now the stenosis. Okay. So it's 61%. 61%. Still asymptomatic. I would go. He's asymptomatic regarding this target lesion. He is asymptomatic. I would check because we are routinely using the FFR measurement several times a day. We have a very good experience, and I mentioned already that we have excellent results with the string trial FFR measurements, and we have more than 300 carotid string sign intervention during the last 5 years, out of about more than 1,000. So more than 30% of our experience is over really critical stenosis. And we are going to measure now the DPR, the non-hyperemic difference in the flow on this carotid level. What is your opinion? I think 60% is asymptomatic lesion is not indicated.
I think it's not indicated, but
Absolutely.
any opinion of the audience?
Equalize.
Equalize. We are going to measure now. Нитънца, дали можеш да покажеш мониторчето на асиста?
Виждаме го.
Супер.
Okay.
You can observe the monitor of the FFR.
Calculate DPR.
So calculate DPR again. Yeah, as expected, it's practically any significance regarding the flow. So we're positioned, yeah, we are well beyond the stenosis, so it's confirming our expectation. It's confirming. So deep blue prism.
Yes.
And you can, Professor Stankov will show you in fact, this is the so-called deep loop. I will have a presentation in several hours regarding, you see how the catheter is coming from the arm. You see, the catheter is coming from here, sitting over the aortic valve. That is absolutely competent in this particular subject. Давай леко лява. And I will show you the next. So with this, in fact, maneuver, we can use radial brachial approach for right and for left carotid, not only in special cases like the bovine arch, but in absolutely ordinary cases in order to avoid femoral puncture and all the possible complications of the femoral puncture. I will explain now to the patient. You will excuse me my Bulgarian. Григоре, всичко е наред, нали? Да, the patient. He sharing, obviously he knows English and he understood. Okay, he understood practically everything, and he agreed not to treat this lesion that is absolutely non-significant. Разбраме. Това е една плака, която е може би около 15-20%. Да, или малко повече, да.
60 според Айвуса.
60 според Айвуса, ама между другото, by the way, what Professor Stankov is saying, it's absolutely right. You see that by the IVUS, definitely the stenosis looks more significant, but nevertheless is not significant enough to be indicated for intervention. So now you are going to see the retrieval of the filter. And yes, this is the retrieval of the filter, and after that the retrieval of the loop of the catheter. We are using for the deep loop, we are using mainly the Cook very hydrophilic sheet, 90 or 110 centimeters. In case we are puncturing the brachial, we are using 90 centimeters long sheet. And in case we are puncturing the radial artery, we are using 110 centimeters. And you are going to observe, yeah, we are protecting the carotid with a very gentle stork wire during the, exactly, because sometimes there is a trend, the sheet during pulling it, to enter the carotid and not to exit, and because of that we are protecting with the wire the carotid. And more or less it was from our part. By the way, we can show you, because the previous procedure was done. Ти можеш ли да извадиш тук на този екран No,
Може.
okay, сега we are going to show you the same patient 20 days ago. We have used the same access, the same vascular access, and we have used the deep loop, the deep loop for the left carotid intervention, and probably our technical staff will succeed to show you. Вие от тук можете ли или не можете? Yes, you are going to see now the recording, the registration of the. In case you feel uncomfortable because you didn't see intervention, but you know that it's very important to know when to stop, not to be aggressive against over the body of the patient.
Hey, Ivo,
Yes.
Frank Criado here. Can I ask you a question?
Of course, Frank. I'm listening to you.
I'm just a little bit surprised that you would do an invasive procedure, the one that you just showed us, on a patient that, on that side at least, clearly had a mild, relatively moderate asymptomatic stenosis for which intervention would not be necessary. I'm just
You're
surprised that
absolutely
you
right.
would do that.
Yeah, in fact, we are practically never do that. We never investigate invasively this kind of stenosis because we have a very good experienced angiology team, and this is really an exception. This is really an exception because there was some wrong data about more significant stenosis on the contralateral side during the previous. So this is the reason to put the patient on the table.
Yeah, how often do you do intervention for asymptomatic stenosis?
30% of our activities is on asymptomatic patients. With more than 80% stenosis in the majority of the cases.
I see. It's interesting, yeah. I mean, for us, you know, it is nearly zero. We have changed over the last several years and essentially stopped doing intervention for asymptomatic disease almost, regardless of the severity of the stenosis.
I see. Yeah, you know, we have quite a good experience with this protocol, let's say, with this practice. The complication rate, it's definitely below 1%. It's following the statistics during the last several years. It's 0.03% of complication rate. So we are performing around 120 cases per year. As I mentioned, mainly symptomatic and around 30 to 35% asymptomatic.
Yeah. Well, I mean, that is important, what you just said, but it is important also to say that for most interventionists, that is not the case. And they have to recognize the fact that the risk of a stroke with asymptomatic disease is at worst in the low single digits. So their complication rate better be very, very, very low, like yours is, if they are going to do that.
Yes, absolutely. Otherwise, it's non-ethical. The old threshold of 5% has to be forbidden even to mention. For me, interventional teams that have more than 3% of composite stroke MI death rate have to be stopped working. Okay, more or less. In case you have some questions and comments, we are on your disposal. Probably the Professor Stankov is ready to show the previous. Okay. Okay, you can. Този екран ли виждат? You probably can observe the screen now, and you see you see the deep loop that was performed. You see how the wire is going up. Next. And this is the target lesion. You see the left one. And as I mentioned, you see the patient is not with bovine arch. It's a natural, absolutely normal anatomy. And even in normal anatomy, we are using the deep loop for the left carotid without any problem. And this is in fact how the stent is coming and sitting on the. You see how the stent is coming and sitting on the stenosis. And of course, after doing that, there is some spasm here in this particular case. This is the cranial. Okay, in case you don't have any comment or questions, I would like to say you thank you for your attention.
Thank you, Ivo. And I don't know if anybody has any questions or comments. Yes?
Thank you very much for a great presentation. Dr. Furcalo speaking. I have some question, especially about intravascular visualization. Is it usual practice for carotis outside the live case? It is not cardiology. I don't know, is it general practice or not? It's a question. And there's short comments concerning asymptomatic patient. Everybody knows as a result of CREST-2 trials that was presented at TCT this year, and maybe the result, they concerning asymptomatic patient, maybe the results will change the general practice, especially in asymptomatic patient. Thank you.
Well, first of all, we have some guides about carotid, where treat or not treat, even if symptomatic or asymptomatic patients. I don't know here in Europe, but there in Mexico we have some guides, but there are not the European guides. We are under the SVS guidelines. So I don't know. For example, I'm going to talk about Mexico. It's some of the patients that go under endovascular procedures, but most of them, they have to be paid by themselves sometimes, and sometimes they are paid by a private insurance. If they don't, we do a lot of open surgery and endarterectomy still. Yes, because they're in the Social Security, where they are vascular surgeons in the third level of hospitals, they do a lot of open surgeries under the same guidelines. So I don't know. About IVUS, in a private hospital, you can use it, and it's under the Social Security. I'm not the Social Security, the private insurance covered, if you need it. And for me, and IVUS is always helpful to measure, like in this case. And not always, I don't do it always to all my patients. I have to be very, because it's not quite of simple or economic for the patient if they are paying for. So sometimes and the personal, I always look at the ultrasound, sometimes with a radiologist, and I check it always my patients with my own ultrasound. So I don't use IVUS for every patient, even only for example, venous stenting, or other procedures, I use it. But for carotid, like now, counting patients, not always. I don't know you.
I have never used IVUS for carotid interventions up to now. In our country, it is not reimbursed, so it's additional cost. And in my opinion, most of the times with duplex echography and CT scan, you can get enough information in order to decide to treat or not even asymptomatic stenosis if it's very dangerous looking or high-grade stenosis. Concerning the question about the results of CREST trial, in my opinion, we should be thinking about the population. For example, in our country, the rate of insults the strokes are very high, and it's difficult to convince the patient to take statins, and we must think of all these things. Probably some patients, even asymptomatic, could do better with endarterectomy or stenting instead of best medical treatment. So, you know, all the trials are perfectly performed, and they are not always the real world. So we still do interventions in and surgery in asymptomatic patients, but not so many, really.
Any other question? Any other comment? No? Okay. I don't know if maybe we can proceed with the next talk, I guess it's me.